you very much for the introduction. I say what I'm going to mostly focus on after that brilliant first talk is the sort of clinical and management aspects of Ebola and some things about the pathogenesis. So my background is as an infectious diseases clinician and a viral immunologist by training. My group works much more on HIV than it does other viruses, but there are some interesting parallels between Ebola and HIV, which I'll mention later on. And also I spent quite a lot of time in West Africa as a research director of the MRC labs in the Gambia. And I have the distinction of 3 former PhD students having been out to work in the current epidemic in different countries, and I'll mention them as I go on. But in particular, very grateful to former student Alex Ligdovich, who is a Canadian Rhodes Scholar and worked in my group on HIV-2, and is now a critical care fellow in Toronto, and has just come back from Liberia, where she's been working with MSF in the initial stages of the brincidofovir trial. So to tell you a little bit about the virus, it's a very unusual looking virus, and the scientists that had those first specimens from the 1976 outbreak were surprised by the length of it under the microscope. And yet inside the virus it's actually a very small genome, just 7 genes, but the whole particle may be really extraordinarily long. And of the 5 species of Ebola that we've already heard about, 4 of those have infected humans, and it actually is a zoonosis also for primates. And so, as we heard, chimpanzees and gorillas outbreaks can often be sentinels for the infection subsequently of humans. And Ebola is the name given following the Yambuku outbreak after a small river nearby. So this is a picture of the virus, so a single-stranded RNA and a lipid envelope. So we already heard beautifully about these very early outbreaks, and I think really all I want to mention is that the Thai forest, where the single case of Thai forest Ebola infection occurred, is also, curiously enough, thought to be the origin of HIV-2, where the City-Mangabe SIV was transmitted first to humans, and that's a subject of great interest to our group. So this is a summary of these early outbreaks. And of note, there are very different mortality rates. And the Zaire Ebola, which is the cause of the current outbreak, has by far the highest mortality. So thinking about transmission, the virus is present in many different bodily compartments, and the virus can be found in the skin, although not in the sweat, and in many different secretions. And necropsy of primates who have been infected, the infective titers are really staggering in solid organs. Fortunately, there's not thought to be any insect transmission, and as we know, it's mostly thought to enter through mucosal surfaces or breaks in the skin. Needle stick injuries can occur, and we've heard those described. And from the Zaire outbreak, those infections due to needle stick injuries had a much higher case fatality than other forms of contact. The WHO has reviewed transmission very carefully recently and published this at the end of last year, and pointing out this particular issue that in convalescent patients, the virus can persist in genital secretions, so it can be present in semen for up to 3 months, and for a shorter time, but still probably several weeks, in the vaginal secretions of previously infected women. It's not a conventional airborne infection, but in theory, the wet droplets full of virus could spread the infection following coughing or vomiting. So it's a short distance, not the conventional aerosol over longer distances that we associate with airborne infections such as flu. And in fact, that last possibility hasn't actually been documented in practice. This is just to summarise where the virus is in the different compartments. It's particularly high in levels in blood, but you can see it's also found in saliva in acutely infected patients, and variety of other secretions with the persistence being longest in sperm. And this just shows you the time course of the antibody response. So IgM can be positive within a couple of days of infection, and IgG is thought to persist lifelong, although not so many people have been followed for decades or more. This is a fruit bat, which is thought to be the origin, and just again to highlight in the infection that secondary hosts can also include apes and major primates. We are a nation of dog lovers, and there was particular angst expressed on the social media during the issue of two dogs with different fortunes. In Madrid, the Excalibur, whose Facebook page is shown on the bottom, was put down when his mistress went into hospital, whereas Bailey, the American dog, was fared better and was in quarantine for 21 days and then reunited with his owner. The evidence about transmission from dogs is not particularly well documented. There was a report from a study in Gabon that suggested that dogs can be infected with Ebola by eating dead animals, presumably small rodents, but clear the virus very rapidly and would be asymptomatic carriers. So it's probably unlikely that either of these dogs would have been a reservoir of infection. So the current outbreak we've heard very well described. The origin is thought to be in this corner of Zaire, around this village here, and has been traced back through sort of careful mapping and epidemiological studies to the original case is a 2-year-old boy whose father was a hunter in the forests, it was the first reports came through from MSF in March describing this illness with a very high case fatality rate. You notice that hemorrhage wasn't a particular feature of these early reports, and indeed hasn't been a particular feature, probably less than 20% of patients in the current outbreak, and then rapidly spread through Guinea along the key roads into the capital, Conakry. And more recently, this is from the end of last year, showing the extent of the outbreak in these 3 incredibly poor countries. They are some of the poorest countries in the world, and people who've spent any time in West Africa will know the infrastructure is very poor. And in particular, all 3 of these countries are only just beginning to recover after many decades of conflict and civil war. So the infrastructure is very poor there, which probably accounts for the difficulties in controlling the current epidemic. And as you'll see there, the average number of doctors are 1 or 2 for 100,000 people. Population is highly mobile, and people tend to have there are high rates of permanent unemployment, and people tend to have migrant work. And in Guinea, a lot of the cases were linked to traditional burials, and that's been one of the hardest things to tackle in the outbreak, is persuading people that they should be able, that they would give up the bodies of loved ones for burial in a safe manner, because the practices are very important locally. And the case fatality is of the order of 70 to 80%. So later on in the year, the epidemic has been described as a public health emergency of international concern, with an extraordinary rapid doubling time for new infections. The projection was for 20,000 cases by early November. Fortunately, that didn't prove to be the case. But obviously, as we've heard, healthcare workers are a particular risk of infection. And so these fragile health infrastructures in these countries have been even further damaged by the loss of many people. And one of the particularly sad things about the current outbreak is that because of the fear of hospitals and the occupation of doctors of the scarce doctors with the Ebola patients, is that many people have died from what would otherwise be treatable conditions, particularly malaria, obstructed labour. And it has been suggested, although again I don't think there's any evidence for this, that the disease could become endemic in West Africa after the infection of people have largely subsided in a rodent or rat, particularly a rat reservoir, in animals that have feasted on the dead bodies that were lying in the streets in the early parts of the epidemic. That I think hasn't been shown, but is not an unreasonable fear. These are some pictures from another of my former students, shown on the left, Linghang Zhang, who was is an infectious disease physician from Beijing and was part of the Chinese response to the epidemic. And he was sent to Conakry, where he worked in this incredibly smart Chinese donated hospital, and actually didn't really get down to the MSF patients. It was a little bit like we were hearing earlier. But he did find that they were useful in looking after the patients that didn't have Ebola in the main hospital, who still need the care. And he wanted to contrast the pictures of the Chinese hospital, or Chinese-built hospital in Conakry, with the MSF hospital, with very different conditions, but doing obviously extraordinary work. So the most recent the figures in November were about 13,000 cases, so not quite the 20,000 cases, and I think we're now up to just over 8,000 deaths. And as we heard in the news over the last couple of days, there does seem to be significant slowing of the epidemic, and particularly in Liberia. And you've seen a figure like this very recently. Of course, what worried many people in the West, and particularly, I think it's fair to say, in the USA, was the potential for Ebola to travel to the countries where there are traditional economic and social links. And the size of the circles in this picture, which is taken from a Nature paper, shows the number of people travelling, and you'll see that obviously illustrates why the contact between Liberia and the States was part of the anxiety there. Although it is said that more people have married Kim Kardashian than died of Ebola in the USA, but that's a small point. So moving on to the clinical side of things, the incubation has a mean incubation of about 4 to 10 days, but it can be up to 3 weeks, and it's thought people are not contagious during this phase, and this has obviously been very important to screening policies. And then presentation is generally with a systemic illness, characteristically with a fever, and then not really very specific signs. Maybe muscle aches and pain seem to be quite prominent. There may be some gastrointestinal upset. Sometimes a rash is described, but all of these are very non-specific and could be related to a lot of other tropical infections. And it's also worth mentioning that there are differences described between different strains of viruses, particularly regarding the likelihood of death and the likelihood of hemorrhage. The pictures on the left are shown from infected macaques, but you can see a purpuric rash in the arm of the top macaque, and then hemorrhage in the gut of a lower in the lower picture. The rash that's described is often quite difficult to see in African skin. And intense fatigue has been described a great deal in the current epidemic. I say hemorrhagic complications seems to be less than 20% in the current outbreak, and probably not much more than that even in the historically reported. And it's the late complications that are so difficult to control. And as we perhaps remember from the British nurse described recently, the patient can be sitting up and looking well to begin with, and then suddenly deteriorate with severe shock and multi-organ failure. And it seems to be around day 6 that people either improve or deteriorate markedly. And convalescence is a problem as well, which I'll go talk about later. This isn't a beautiful slide, but it does illustrate very graphically how the virus progresses through the human. And convalescence, as I mentioned, isn't straightforward. Many people suffer recurrent symptoms: joint pain, muscle pain, feeling weak, loss of appetite, and psychosocial disturbances are quite major, as you probably all know. Stigmatization of patients who've recovered from Ebola is a perhaps not surprising feature of the epidemic, so that people who are well after infection have had difficulty in getting back to normal life. And Alex sent me this picture from Monrovia to show a brother and sister. They were both admitted with a fever. The brother recovered very quickly and was able to go home, but he stayed in hospital a further 10 days to look after his sister until she was clear. And they're being given there the certificate to show that they're Ebola free. And this is something that MSF has instituted, and I think is a very good way of trying to counteract this very severe stigma. So if you were investigating a patient and you had access to lots of tests, these are some of the things that you would find. The white count is low, the platelets are low. Again, that doesn't necessarily help you from distinguishing from other infections. Surprisingly, the C-reactive protein is normal. The liver function is often distorted, and particularly the AST, and then subsequently a development of coagulopathy, often leading to disseminated intravascular coagulation. And it's the development of the adaptive immune response, particularly antibodies, but my guess is also a good T-cell response, coincides with clinical improvement in people who do recover. And they also have particular cytokines associated with a good outcome, whereas the fatal cases have markers of continued activation and liver failure. This slide just is there to illustrate that even in the middle of an Ebola outbreak, not everything with a hemorrhage is necessarily due to a viral hemorrhagic fever, and there are various other things that need to be excluded. And so these slides come from Alex's handover slides for the volunteers coming in after her to Monrovia. So this is really what you do when you think you have a suspect case. So it's looking really for the contact and fever, and then 3 symptoms from a list of 10, which I've highlighted in red on this. So that determines whether somebody comes to an Ebola treatment centre. And then the sample collection is really to look at basic biochemistry and to make a diagnosis. And it points out that when you're wearing the full equipment for which is required to take blood, it takes at least 15 minutes to collect the sample. And then the analyses are done in containment facilities. And these is various stages that need to be gone through to make sure that the sample can be safely handled both by the sample taker and the people who will analyse it at the other end. So there's many stages of having to spray the inside of the bag and the outside of the bag and so on. We have to get a courier to take the samples then from our ward to the hospital labs, and they have to be paid an inordinate amount of money to transport Ebola samples, potential Ebola samples, although we haven't had a positive yet. So mentioning another PhD student, Clayton Onyango, went quite early on. He did his PhD with me in the Gambia and is a Kenyan national now working with CDC in Kisumu. And he went quite early on to help set up a diagnostic lab in Monrovia last August. And although IgM can be used as a diagnostically, it's really now the basis for diagnosis is a PCR test looking for viral nucleic acid. And this is a fairly standard test for a number of different organisms. It's very sensitive, and the test used quantifies the virus so that the number of cycles need to reach a threshold gives you an idea about the relative viral load. And the importance of that is that there's a fairly clear relationship between the height of the viral load, particularly in the first few days of infection, and the likelihood of death. The pathogenesis, I think, is incompletely understood, and I think this might be another area for research which could be helpful in trying to establish the best management. The virus tends to infect macrophages and dendritic cells, not lymphocytes, but lymphocytes die by a sort of bystander apoptosis. And the virus has particular tropism for lymphoid tissue, the liver, leading to this massive necrosis and development of liver failure, and also the adrenal glands. So shock may be resistant to treatment with fluids because of a shortage of the adrenolocorticoids, which are needed for managing vascular stability. And it's also important to note that the virus has developed, despite only having 7 genes, many different ways of evading the immune system, presumably developed in its, to respond to its rodent host or bat host rather than to avoid humans. But it's particularly good at interfering with the innate immune response, the type 1 interferon response. And that's one of the reasons that type 1 interferon alpha or beta have been suggested as a treatment and tried in certain cases. And one of the issues potentially about convalescent serum is that you make, and this is very similar to HIV, you make lots of antibodies, but only a few of these will actually neutralize the virus. So the virus envelope, it's a lipid envelope, heavily glycosylated and very difficult to neutralize. So the difference between the monoclonal antibody therapy and ZMapp is that there are 3 very carefully selected monoclonal antibodies which have been shown in the laboratory and in animal models to selectively neutralize and to work together to neutralize Ebola. Convalescent serum will have a whole lot of rubbish antibodies in, which may actually contribute to pathogenesis if they facilitate uptake of the virus, which some interfering antibodies can do. So although clearly there's good reason for trying convalescent serum, it won't necessarily be as good as the monoclonal antibody therapy. And a T-cell response, a good coordinated cytotoxic T-cell response, appears really crucial for recovery. And that might actually be a useful way of distinguishing the patients who are going to do well and those who are going on, those who need perhaps more urgent intervention. So this is again this is more graphic illustration. So the dendritic cells and the macrophages are the main target. Virus can actually directly infect the liver, endothelial cells, and affect causing vascular leakage. But it's probably this massive secretion of pro-inflammatory cytokines, leading to a kind of cytokine storm that causes the very severe illness in those who go on to have a bad outcome. And lymphocytes are depleted but not infected. So management, we've heard a bit about some of the principles of management, and a lot more has been written recently. As I guess is obvious, there isn't any licensed treatment currently for Ebola, and supportive care is clearly the mainstay of management. Now, for very good reasons, given the limited infrastructure available, the instructions to the MSF personnel is to look after their own personal safety first, and being particularly careful about handling sharps. Although the principle of managing severe volume depletion is with intravenous fluids is a good one, oral fluids are tried first, and really only using parenteral access if the patient isn't improving. Quite often, and particularly because the patient is relatively immunosuppressed, empiric antibodies and antimalarials are given, and then supportive treatment to manage pain, fever, nausea and diarrhea, and everyone gets multivitamins as well. The key points really are to try and support the circulation. Highlighted here is that many patients, despite the best available care in these Ebola treatment centres, will die, is therefore also in these horrible circumstances to manage death with as much dignity as possible. And I mentioned the brother who stayed to care for his sister, involving survivors in the care of patients with Ebola, because they appear to have lifelong, or at least long-term immunity. Maybe another way of counteracting some of the stigma associated with being an Ebola survivor. And pregnant women, as you've probably heard recently on the news, have a particularly high mortality, and a special treatment centre for pregnant women was recently opened. And very young children also do particularly badly. The limitations of care Alex has highlighted in this slide, that it's very difficult to, the amount of time that you can spend with each patient is limited by this very laborious wearing of personal protective equipment, the concerns about using needles and limiting intravenous access and any other invasive techniques, all again put limits on the care of patients in West Africa, which you wouldn't necessarily have in the developed world. But many patients do recover, and these are the criteria for discharge. They do use lab tests, and so giving people a certificate of a negative lab test after clinical improvement is a very important sign. And you'll see here from Monrovia, there's a wall where people are encouraged to put their handprint and sign when they recover. And I mentioned earlier about the protracted excretion of the virus in semen, so men are supplied with condoms and encouraged to use them for 3 months after recovery. This is the wall, or a big section of the wall of showing all the recovered patients who are recorded there. So briefly, just to touch on the experimental therapies, brincidovir was developed as a drug for CMV and also the BK virus you see in patients following renal transplantation. It has some clinical use, but isn't at the stage of being licensed yet. That is one of the drugs that has been tested as part of the ISARIC collaboration that we heard earlier. It took a while to get the ethical approval for this in Liberia, but the first patients were started in the trial of this drug earlier this month, and that was what Alex went out to do, or to be part of the preparations for this trial. I mentioned ZMapp. There are other treatments. There's a drug called TKM Ebola, which uses antisense RNA. This works very nicely in non-human primates, but probably has to be given very early in disease. And I guess it's likely that most of these drugs really work best in patients treated very acutely. This is ZMapp arriving in Liberia to treat the 2 Americans who had become infected. And it's a mixture of these 3 antibodies picked out from a selection of different monoclonals. And part of the reason the supply proved a problem is that it's generated in plants, and so it takes it's a very economical way of producing these antibodies, but it takes some time for these plants to grow and produce the necessary amount. So although supplies of that are likely to be available in the next few weeks, again, there was a gap when it wasn't available. And it's shown that it's 100% effective in macaques against a lethal dose of Ebola, even when given at the time the animals were already ill. And there are 2 Ebola vaccines that have gone through phase 1 trials. One is a VSV recombinant vaccine. And the second is the vaccine that we heard about on the news today, developed by the NIH and GlaxoSmithKline and tested in human volunteers for safety in Oxford and in Mali. The paper describing the immunogenicity and safety profile of that is coming out next Thursday in the New England Journal, and I wasn't able to get a preview of it, but I gather it's good, and because, as you know, it's already being shipped out with the intention of using it in healthcare workers. And it is clearly possible, as Professor Heyman illustrated so well, to contain Ebola even in densely populous countries with poor infrastructure. So these 3 neighbouring countries all had cases of Ebola. In the case in Lagos led to 20 subsequent cases and 8 deaths. And there was real horror that the virus had got as far as Lagos. It's a very chaotic city, but in fact it was well contained and didn't spread any further in the population. So Nigeria, Senegal, and then just this week Mali have all been declared Ebola-free after a very small number of cases in each country. So I'm going to stop there and thank particularly Alex, shown on the right-hand side where she worked in Guinea-Bissau for her PhD, and in the middle in her full PPE in Monrovia. And thanks very much for your attention.